Rory, let's go ahead and start the live stream. Is a meeting of the Public Health and Minority Health Disparities Subcommittee. We have a packed agenda today for all of our stakeholders. We have a couple of bills that we're going to hold because we still need we're still working some things out. So if you are here on House Bill 386, pesticides, PFAS chemicals, we're going to hold that bill. If you are here on House Bill 1142, Public Health Maryland Interested Parties Advisory Group, we're going to hold that bill. There's not a problem. We just got the amendment, so we want to give our council some time to breathe. And House Bill 1289, drug and alcohol treatment programs, discharge of patients and referral services standards. Oh, sorry, that one. That is not a hold. That is being folded into another bill. Aaron, am I missing one? Okay, so this one is not a hold. So we are holding House Bill 386 and House Bill 1142. So we will not be taking those bills up today. We are going to start with House Bill 1131. This is the Public Health Buprenorphine training grant program and work group. I believe there are no amendments on this bill. Erin, if you can talk us through the bill.
The bill establishes the buprenorphine training grant program in MDH to assist a county with offsetting the cost of training paramedics to administer buprenorphine. A county may apply to MDH for a grant from the government. A county may apply to MDH for a grant from the program, which may only be used to train paramedics to administer buprenorphine. The governor must include an appropriation in the annual budget bill of at least $550,000 from the opioid restitution fund for the program. The authorized purposes of the ORF are expanded to include the program, and the Maryland Office of Overdose Response must establish a work group to study access to buprenorphine in the state and report to specified committees of the General Assembly by December 31st, 2025.
Thank you, Aaron. And for the members, this was the bill that looked at buprenorphine, as post overdose, and works with the with MOOR. It does meet the threshold for the fiscal note. With that, do I have a motion on the bill?
Move favorable.
Second.
All right, it's been moved and seconded. Do we have any further discussion? Seeing no hands, all in favor of House Bill 1131, say aye.
Aye.
Anyone opposed? Go ahead and raise your hand in the chat. All right, so that one does pass unanimously. All right, we are going to turn to House Bill 1146. This is the Maryland Behavioral Health Crisis Response System integration of 988 suicide and crisis lifeline network and outcome evaluations. Aaron, if you can talk us through the bill and the amendment.
The bill has altered the program and reporting requirements of the crisis response system by requiring each crisis communication center to coordinate with the 988 suicide and crisis lifeline to provide the lifeline's full range of services, including supportive counseling, suicide prevention, crisis intervention, and referrals to additional services. In addition, each crisis communication center is required to provide an evaluation of outcomes of services in each jurisdiction or region, and data derived from the evaluation must be collected, analyzed, and publicly reported by December 1st of each year. There is a reprint that has been provided that incorporates amendments that are being offered by the bill sponsor, who is Delegate White Holland. If you look on, starting at the bottom of page 1 of the reprint in line 18, requires that the crisis response system must include a state 988 suicide and crisis lifeline in each jurisdiction or region, provide a single point of entry to the crisis response system, coordinate with the national 988 suicide and crisis lifeline to provide the full range of services provided by the national 988 suicide and crisis lifeline. And then it adds to the services of the bill as introduced direct dispatch or warm handoffs to mobile crisis response and stabilization services and other immediate services as needed. If you move on to bill page 3, at the bottom, it requires this evaluation of outcomes and services, and it adds to those services on bill page 4, beginning in line 14, that through data obtained from consumers and family members who have received services from the crisis response system, that that's collected through ongoing data collection from 988 call, text, and chat providers and other crisis providers that is reported annually. And then there's new additional language on line 17 that also this data would be provided through annual crisis services data collection on the involvement of law enforcement, involuntary status of clients, and diversion from higher levels of care, including hospitals. The amendments require that this collection and analysis of the data would begin on or before December 1st of each year, beginning in December 2026.
Thank you very much, Erin. Do I have a motion on the amendments?
Move the amendment.
Move. Second.
All right, they've been moved and seconded. Any discussion on the amendments? And thank you to the bill sponsor for working on this. These are really appreciated. Delegate Riley. Oh, go ahead and unmute.
Before you tell me to unmute. So before we move on, I guess it deals with the amendment since we've added some
Yes.
additional data. So how did that affect the fiscal note? Did we get the fiscal note down originally and did this take it back up, or are we good? 'Cause originally it was like 63.
Delegate White Holland,
Johnson.
do you have a response?
Yes, thank you, Madam Chair, and Aaron, I welcome you to chime in if I don't get this right. But based on the fact that we are supportive of the amendment that would push the report to 2026, it would in fact lower the fiscal note. In the original fiscal note, it was, as you said, $95,995. This accounted for a part-time epidemiologist, and a health policy analyst. And so the total FY26 cost in the updated fiscal note would be $46,984, as the epidemiologist would no longer be required. And so it would lead to a cost reduction of $49,011.
Thank you very much. Appreciate it.
Thank you so much. Any further questions on the amendments? Any further discussion? All right, all in favor of the amendments, say aye. Anyone opposed to the amendments, go ahead and raise your hand. Give it a moment. All right, seeing no hands, do I have a motion on the bill as amended?
Move the bill as amended. Second.
All right, it's been moved and seconded. Any further discussion on the bill as amended? Delegate Chisholm.
Thank you, Madam Chair. And I hate to ask you this, is this the bill that Jen Corbin came in favor of? Our crisis response team in Anne Arundel County, do you remember?
Delegate White Holland, I see you've unmuted. Go ahead.
Yeah, so I cannot say that Anne Arundel County specifically chimed in on this bill. The only county that chimed in on this bill was Montgomery County. And one of their 2 amendments has been incorporated in this set of amendments that we've adopted. But we have been working closely with the Maryland Department of Health and the Behavioral Health Administration, and who I believe are here. So I cannot say that Anne Arundel specifically chimed in on this bill, but given their work in collaboration with MDH, and knowing that MDH is, working in concert with our local health departments, I cannot be certain, but it didn't appear that there was any unreadiness amongst other local health departments, more
Perfect.
specifically.
Good enough for me.
Thank you, Delegate White Holland. Thank you, Delegate Chisholm. Any further discussion on the bill as amended? Seeing none, all in favor of House Bill 1146, say aye. Anyone opposed, go ahead and raise your hand in the chat. All right, thank you so much. It passes unanimously. And thank you for all of your work to the bill sponsor, because I know you have been working diligently. House Bill, all right, trying to read my notes. House Bill 1066, Commission on Behavioral Health Care Treatment and Access, Membership and Work Groups. Aaron, if you can talk us through the bill and also speak to House Bill 12, is it 1289?
1289, yes.
1289 as well. Thank you.
This bill, as introduced, would have added 7 members to the Commission on Behavioral Health Care Treatment and Access, and required the commission to establish an additional work group on improvement of health, social, and economic outcomes related to substance use. The work group would be required to evaluate and review specified issues and make recommendations on changes to state laws, policies, and practices needed to mitigate the harms related to the criminalization of substance use, with the goal of improving the public health and safety of residents of the state. There is a reprint of House Bill 1066 that incorporates amendments that are being sponsored by Delegate Bagnall. And if you move to page 4 of the reprint, this would strike the addition of the 7 additional members to the Commission on Behavioral Health. And then continuing on to bill page 6, the bill is introduced. The bill does still require this establishment of a work group on improvement of health, social, and economic outcomes related to substance use. And the charge of this group is to evaluate and review the availability, affordability, and accessibility of treatment for substance use disorder and recovery support services, including housing and employment services. This work group would also focus on the impact of mandated treatment versus voluntary treatment. Then the amendments start on after line 16 of bill page 6. And this is the attempt to incorporate the provisions of House Bill 1289. The work group would be required to evaluate and review the department's regulations on the standards for the discharge of patients from substance use treatment programs to assess whether the standards adequately consider the patient's mental health or substance use disorder diagnosis and the impact of the discharge standards on the patient. And then further, after line 20, the work group would make recommendations on changes to state laws, policies, and practices related to the discharge of patients from substance use treatment programs to consider the patient's mental health or substance use disorder diagnosis in making an appropriate placement.
Thank you, Erin. And now let me quickly explain this, Frank and Bill, so we all understand what we're looking at. The reason that we amended it was to better align with how the work groups are defined in the existing Behavioral Health Commission. We have also discussed that I would like to request a letter from the committee, just affirming that we would like to see these stakeholders represented. But this does give this gives the department some flexibility, and if you recall, Delegate Howard brought in a bill. He brought it in last year on a treatment step down plan on a discharged treatment plan. Last year, we turned it into a study. We now have that report. So this work group would be charged with actually looking at that report and helping us make recommendations on establishing the treatment plan. So we would actually be able to meet the charge of or the intention of the bill that Delegate Howard has brought forward. With that, do I have a motion on the amendments as they've been explained?
Move the amendments.
Second.
All right, they've been moved and seconded. Any further discussion? Secretary Lord.
Good afternoon, everyone. Appreciate the opportunity, and we support the intent of the legislation. I think the department continues to have concerns regarding the establishment of an additional work group when much of this work is already underway. And I think we've shared quite extensively the work that we're doing around the revisions to COMAR 1063, which should hopefully address some of the latter concerns regarding discharge planning And then there is a fiscal note to this. The establishment of the additional work group will require additional staffing to support this. And as it is with the commission, we already have anywhere from 10 to 12 different Maryland Department of Health staffers that are supporting both the commission as well as the joint meetings between the commission and the BHAC. So we appreciate the opportunity to be heard, but also recognize that from our perspective, this work is already occurring, and that we would appreciate the opportunity to continue without having the formation of an additional work group to execute on these key priorities.
Thank you, Secretary Lord. And I will point out that to just for the edification of the body, there was a fiscal note that was reflected. This did come from DLS. The work groups do not require the full commission meet. They can meet independently. And part of the original commission was reviewing existing materials. You may recall that they had 65 reports that they reviewed. That was year one. So I leave it to the subcommittee, but I do believe that there is value in having a work group that is tasked with looking at the continuity of care for our substance use disorder community. And I believe we're on the amendments. Is that correct? Did we move and second the amendments? Aaron?
Yes.
Okay, thank you. All right, so we are on
Move
the
the bill
amendment.
as amended.
Let me take the vote on the amendment because I think we were still in discussion on the amendments. All in favor of the amendment, say aye. Thank you. Anyone opposed, go ahead and raise your hand. All right, do I have a motion on the bill as amended?
Move the bill as amended.
Do I have a second?
Second.
All right, it's been moved and seconded. Any further discussion on the bill as amended? All right, all in favor, say aye. Anyone opposed, go ahead and raise your hand in the chat. All right, Delegate Riley. Delegate Hutchinson. Delegate Chisholm. Okay. Hold on one second. I just want to make sure I get that down correctly. Okay, Riley, Chisholm, Hutchinson. All right, thank you very much. That was House Bill 1066. We are now going to House Bill. Oh my gosh, I can't read my notes. House Bill 290.
Okay.
Thank you.
Okay.
Delegate Chisholm, is your hand still up from before? Okay, just want to double check. House Bill 290, Office of the Chief Medical Examiner's disclosure of autopsy information and maintenance of investigative database. Aaron, if you can walk us through the bill and the proposed amendments.
This is a departmental bill, and it requires the Office of the Chief Medical Examiner to maintain a Chief Medical Examiner investigative database that includes records on each medical examiner's or forensic pathologist case, except for a final autopsy diagnosis, electronic data or records stored in the database, or a comparable database managed by OCME for use in any medical examiner's case is not considered a public record and is exempt from inspection under the Maryland Public Information Act. A custodian must deny inspection of the part of the public record that contains medical or psychological information about an individual other than a final autopsy diagnosis. There is a reprint that has been provided, and these are amendments that are being offered by the Department of Health. If you look on bill page 2, the definition of final autopsy diagnosis is altered, stating that it means the interpretations and conclusions of a medical examiner or forensic pathologist that are part of an autopsy report, including the name, age, gender, and race of the decedent, cause and manner of death, including a list of drugs that caused or contributed to death, and the medical opinion of the facts informing the conclusion. And then this same definition is copied again under the definition of final autopsy diagnosis that appears on bill page 3. There is an additional amendment at the bottom of bill page 3 that provides that except for a final autopsy diagnosis, electronic data, or a record stored in the chief medical examiner investigative database is a registered record instead of the language saying it's not considered a public record. It would be a registered record and is exempt from inspection under the Maryland Public Information Act. There's an additional language stating that the OCME shall consider in good faith any proposed data sharing agreement by a requester. And then on bill page 4, after line 24, language stating that nothing in the bill would be considered to limit discovery rights under Maryland Rule 4263. And these are the department's amendments.
Thank you, Erin. Let me go to Delegate Whitehall, and then I may have a question. Go ahead, Delegate.
Okay. Thank you, Madam Chair. I wanted to know if these amendments that were proposed by the department addresses any of the concerns that were elevated during the hearing, and if there have been any sort of discussions with people, with some of the opposition, given where we are with the bill. And then I may have a few other questions, but I would just like to know what is the status of that.
Thank you, Delegate Whiteholland. Do I have from the department who can best answer? Stephanie Dean.
Thank you, Madam Chair. I'm the Chief Medical Examiner. I'm one of the representatives from Maryland Department of Health. I can say that there have been ongoing numerous conversations with representatives from the Maryland Press Association to try to get closer with our language and address concerns on both sides. And so those discussions are active and ongoing.
Thank you. Let me go to Delegate Alston and then Delegate Whitehall, and I'll come back to you. You just muted.
Thank you. I think you said there were ongoing discussions with the press. Have you all talked with ACLU?
We have not. That was not a group that approached us or that we have been able to make contact with, to my knowledge. I personally have not spoken to them. I can't speak for Deputy Secretary Dr. Kalyana Rauman. He may have had additional conversations, not to my knowledge.
Thank you. Madam Chair, I'll have additional questions or concerns whenever you're ready to hear those.
Yes, let's go, because I think given the questions, we're probably going to hold this bill, but let's go ahead and get our questions now so that we can get answers for the next subcommittee. Does that sound reasonable? All right, so let me go back to Delegate Whiteholland, and then Delegate Alston will come back to you. And if anyone else has outstanding questions on this bill and the proposed amendments, go ahead and raise your hand in the chat so we can get them on record now. Go ahead, Delegate.
Yeah, so I just wanted to also get an understanding around, the notion that full records would only be available to those with data sharing agreements with the medical examiner. Can you expound upon that a little bit more as to why that should be the case and how it differs from what the current practice is?
So I will say that the data sharing agreement that is mentioned in the bill is specifically for PIA requests regarding the data that is stored in our investigative database. It would not apply to, say, a next of kin or any other member that is by law allowed to have a copy of the autopsy report. This is strictly to protect the sensitive data such as addresses, next of kin contact information, results from infectious disease testing. All of that is stored within our database. And so the goal is to protect that and, but of course, consider in any in good faith, any data sharing agreement that might be presented.
Madam Chair, follow-up.
Go ahead.
So if that is the case, right, and I understand that, and that we certainly want to protect any sort of privacy of the individuals, when these requests are made. But is there a way to have any sort of redacted, have a redacted version of that type of sensitive information before it is released? Was that ever considered in the conversations?
So redaction was considered and discussed at length. Unfortunately, the way that the law is currently written, there's not much that we can redact. So currently, the entire autopsy report is considered public record. There's nothing much that we can redact out of that. And currently, the investigative database does not have any definition or safeguards currently in the law. It's not mentioned anywhere else.
All right, Madam Chair, I'll yield my time to Delegate Austin, but I may have a few more things later. Thank you, Madam Chair.
Of course. Delegate Austin.
Thank you. I think what I would like to recommend is that you all talk with the ACLU, because I recently got a list of concerns that they have raised, and they concern me as well, about the availability of information and how that can hamper the public's ability to understand what's happening in our state. So I think it's a lot to go over, and I just literally got it walking in to this meeting. So I would like time, and I think we're going to hold a bill to look at it, and I will send this over to Ms. Dean, and I think it's Ms. Johnson from the ACLU. Someone needs to reach out. I think she's new, so maybe that's why they're a little behind. But we definitely need to look at some of the concerns that they've raised.
And Delegate Alston, can I ask you to touch base with Aaron, and we'll make that request?
Yes, absolutely.
Okay.
Thank you.
Of course. Are there any? Thank you, Aaron. I'm not trying to make more work, but I do want to make sure that we have answers. So again, we are all confident on what it is we are voting on. So we're going to hold this bill. Are there any further questions on the proposed amendments or the bill before we hold it? Aaron, I saw you unmute.
I'm good.
Oh, you're good. Okay. All right. We're going to go ahead and hold 290 for some outstanding questions. But we've had a good discussion, so thank you, everyone. We are now going to, let's see, time check is 250, so we're doing well. We're going to go to House Bill 1244. This is the Maryland Developmental Disabilities Administration Waiver Advisory Council establishment. Aaron, if you can talk us through the bill, and I believe there's a technical amendment. Is that correct?
It's more than technical, but there's a reprint.
Oh, there's a reprint. Sorry.
Yeah. So this bill would codify the Maryland Developmental Disabilities Administration Waiver Advisory Council in DDA, and it incorporates alterations to the membership compared to the existing council. Members of the DDA must include a dedicated council webpage on their Department of Health website that includes certain information. So there is a reprint of the bill. The idea of this legislation is that there is this current Developmental Disabilities Administration Waiver Advisory Council that is not codified. So this would essentially codify that council. The amendments, there's an amendment on bill page 2 of the reprint that increases the membership from 18 to 20 of individuals with lived experience participating in an administrative, in a DDA program. And then on bill page 3, it adds a representative of the Maryland Association of Community Services and a representative of the ARC of Maryland. That's actually just kind of a transfer of where those organizations appeared in the bill. Originally, on bill page 4, after line 24, it provided that the licensed or certified providers on the council would include representatives from each region and from MACS and the ARC. That was not how the current council works, and it just put them in the right place in the council. And Delegate Guyton approved that amendment at the bill hearing. She introduced the bill with that amendment in it.
Thank you very much, Erin. And just as a reminder, this is codifying the existing advisory council, doing a little bit of right sizing, and gives them a seat at the table, because as you know, we've had some ongoing challenges with the implementation of our self-direction services.
And I'm sorry, Delegate Bagnall, essentially you are correct. That is, it's not technical, but it needed to happen because it doesn't reflect the current.
It doesn't, yeah, it doesn't reflect the current membership. So thank you very much. Is there a motion on the amendments?
Motion to move the amendments.
Second.
All right, they've been moved and seconded. Any further discussion on the amendments? All right, seeing none, do I have a motion on the bill as amended?
Move the bill as amended.
Second.
All right, it's been moved and seconded. Any further discussion? I do see that we have the bill sponsor here. I just want to thank you for your work and your dedication and working with us to make sure that we didn't end up with a fiscal note, but that we are actually going to be doing good work. With that, it's been moved and seconded. Any further discussion on the bill? Seeing none, all in favor say aye. Anyone opposed, go ahead and raise your hand in the chat. All right, House Bill 1244 passes unanimously. Thank you, everyone. All right, we're cranking through. Thank you so much. House Bill, and just again, as our chair always says, these are bills that we've considered. We've heard the hearings. We've been working with the sponsors. We've been working with the stakeholders. This is our opportunity to look at the work that has been done. So this is House Bill 1053. This is the Developmental Disabilities Administration Self-Directed Services Parent Providers. Erin, if you can talk to us about the bill and also the proposed amendment.
The bill clarifies that a parent of a recipient of self-directed services must have the option to provide specified services for the recipient if the recipient or an individual authorized to make care decisions on behalf of the recipient chooses the parent to provide the services, and the recipient also hires a support broker. There is an amendment that is in a reprint that's being offered by Delegate Bagnall, and it's on page 2 of the reprint. So under current law, the bill as introduced would amend the current law to, as I just said, clarify that a parent could provide the services. There is additional language stating that if the parent is chosen by the recipient, that the services are authorized to be provided by the parent, another family member, or legal guardian of the recipient by a developmental disabilities administrative waiver that's approved by CMS.
Thank you, Erin. And just a reminder, this is already best practice. It's already allowed, but this is clarifying, and it's clarifying what programs where a parent can be identified. Delegate Alston.
Yep, I just want to make sure this is already current law that parents can provide this service and care.
It is.
Are we adding any additional hurdles to the parents being able to do that?
No, this is actually an attempt to clarify that this is already standard practice. As we heard in the testimony, there doesn't seem to be consistency with how this is interpreted and implemented. So this will give clarity to all providers and participants. Delegate White Holland.
Thank you, Madam Chair. Just very quickly, because this is adding clarification and given all of the concerns and the information in which that we've been receiving from constituents regarding self-direction, I wanted to know, or if anyone can speak to, how will this help improve the current systems that exist to ensure that these, to ensure that these services can be, received in a timely fashion. And so because this is clarification language, I just wanted to know if there is, if it will help improve the processes and mechanisms that are already in place.
Thank you, Delegate White Holland. And I would say, I think that is the intent. I think it clarifies that parents have standing and that they already have, have this right under community-based services, under self-direction, that there are services that are already authorized to provide, to be provided by the parents. And this just clarifies that parents have the same standing as any other family member in providing services. Does that answer your question?
That's fine, Madam Chair. I just, I think the whole thing is that, we know if it is already an existing, aspect that is happening in practice, I just would like to know, is this going, and I think, again, the intent is to help further expedite and to ensure these services can be rendered in a timely fashion.
I think this is to try and avoid having to go through a denial and an appeal.
Okay. All right. Thank you.
So that we're clarifying that they should not be denied, that they have the same standing.
All right. That's it. I'm good.
Thank you. And thank you for the question, because it does help clarify it in my mind as to how to answer it.
Thank you, Madam Chair.
Anyone else have questions on the amendments? We've moved the amendments, right? Moved and seconded. All right. All in favor of the amendment, say aye. Anyone opposed, go ahead and raise your hand. Do we have a motion on the bill as amended?
So moved.
Do I have a second?
Second.
All right, it's been moved and seconded. Any further discussion? Thank you so much. All in favor, say aye. Anyone opposed, go ahead and raise your hand in the chat. Thank you so much. 1053 passes unanimously. And thank you again for the discussion, because we know that we are trying to find solutions, because we're all hearing from our constituents about the challenges that they're having. So that was 1053, correct? All right, we are going to House Bill 1083. I'm going to do a time check. It's 1 o'clock. You all are amazing. It is we're going to 1083. This is the Maryland Department of Health Work Group to implement early and periodic screening, diagnostic, and treatment requirements. Aaron, talk us through the bill and the reprint, if you would.
So I sent this reprint right before subcommittee, so it'll be the last reprint that you just received. The bill as introduced would have required the Department of Health to convene a work group on to implement early and periodic screening and diagnostic and treatment requirements. The reprint changes that format of the bill, and instead would require the Commission on Behavioral Health Care, Treatment, and Access, through its work group on youth behavioral health, individuals with developmental disabilities, and individuals with complex behavioral health needs, to create a plan to implement the recommendations in CMS's State Health Official Letter 24-005 on best practices for adhering to EPSDT requirements for children. And they would have to look at screening and assessment of behavioral health conditions, the feasibility of implementing the DC-05 diagnostic classification of mental health and developmental disorders of infancy and early childhood as a diagnostic tool for parents under the age of 5 years, community-based services to correct and ameliorate a wide range of behavioral health conditions, and services to ensure children's behavioral health, address early symptoms of concern, and address urgent and crisis needs. On or before December 1st, 2025, the Commission will report its findings and recommendations to the General Assembly.
Thank you, Aaron. And can you just remind us, these amendments came from the
Delegate
sponsor?
Woods, the bill sponsor.
Yep, they came from the sponsor. Thank you. Do I have a motion on the amendments?
Move the amendments.
Second.
All right, they've been moved and seconded. Do we have discussion? All right, Secretary Moran.
Yes, I just want to clarify, maybe a question for Ann. And these were the amendments that we worked on collectively together between us and you all. Is that right? 'Cause I don't think I've seen the most updated copy of the amendment.
I'm actually not clear, which is the latest amendment, because I saw something yesterday that I don't think reflected,
Okay.
the final version. And so I'm not 100% clear. So
Okay.
I think I'm sorry?
Go ahead.
I think the main question is, does the stakeholder group, does the list of stakeholders, does that remain in the bill?
No. They're not in the bill.
And that was something that was important to the proponents of the bill, acknowledging not creating something separate from the department's commission, but acknowledging that there would be a work group that would be, providing some input to to the commission.
So, Madam Chair, thank you. We've been working obviously with Ann on some of this amendments, and I personally would like to take a look at them, make sure that we're all aligned, because I think we have good due diligence that we want to come to the same page here and ensure that this moves forward.
I think it's reasonable to hold the bill and make sure we have those discussions, because as our council said, these are hot off the presses, so we want to make sure we've got the right information. Did I see a hand from Delegate Woods, Chief of Staff?
Sorry about that. You can. Yeah, you don't have to worry about that. Sorry.
Okay, no problem. We're going to hold this bill to make sure that everybody is looking at the same amendments. Again, we're doing well. We've got time, not a lot of time, but we have enough. So we're going to hold House Bill 1083 so that we have time to review those amendments.
Thank you, Madam Chair.
And if I can ask, Aaron, can you just go ahead and send them to Ann and Secretary Moran? You're already nodding your head. You've probably already done it. So thank you. And then if I can ask you all to consult today and get back to us later today, that would be great, just to make sure that we're all on the same page. Thank you very much. That was 1083. So we are going to go to, now I can't read my numbers.
871.
Thank you so much. House Bill 871, Health Services Cost Review Commission, Community Benefits, Community Health Worker Workforce Program. Aaron, if you can talk us through the bill and the amendments.
The bill alters, sorry, there is a reprint of the bill with an amendment offered by Delegate Bagnall. The bill alters the definition of community benefit to include a community health worker workforce program between a nonprofit hospital and a community-based organization. The purpose of the workforce program must be to provide services to patients of a nonprofit hospital that are intended to improve health outcomes and address social determinants of health. A nonprofit hospital and a community-based organization may collaborate to identify financial resources to address costs associated with increasing administrative capacity within the community-based organization that are necessary to participate in the partnership. There is an amendment in the reprint that has been provided on bill page 4, lines 27 through 30. The bill is introduced required that the partnership established provide health insurance coverage to each community health worker for the duration of the program if the individual does not have health insurance coverage. And this would make it that the partnership could provide health insurance and authorization versus a mandate.
Thank you, Aaron. And for the body, these are consensus amendments. As I mentioned before, we were trying to figure out where to put the mays and where to put the shalls. The community-based organizations and the hospitals asked for some flexibility. The community health workers asked for some, some legislative intent. And so with that, I would ask for a motion on the amendments.
Move the amendments.
Second.
All right, they've been moved and seconded. Any further discussion? Delegate Hill.
Thank you. And I just want to, I'm reading line 27. I want to make sure I understand what it means. A partnership established under this section may provide health insurance coverage to each community health worker for the duration of the program if the individual does not have health insurance coverage and requests coverage. They may, in circumstances where they would not, would be if they're, why would they not?
The concern was needing flexibility, because if one organization was offering health insurance and they were no longer working with that organization, would they then be required would the other organization then be required to offer it under the MOU? So it was a consensus, just a request for flexibility, because not everyone was deemed to need health insurance, and also their circumstances may change, and the MOU would lock them into a determination at the beginning.
So
of
let
the
me ask, if I may, Madam Chair. So why did you all not consider, or why did you reject for the duration of their employment in the program as opposed to May? And it does say that they have to request it. So yes, there are people working who may have health insurance somewhere else. So you don't supply to someone who has health insurance, through their spouse or something and doesn't need it, or who's no longer working, but this makes it like they've requested it, but we don't have to do it.
And that was the concern that we went back and forth.
But if it says while they're, if you change it to what the concern is, do we have to continue after they're no longer employed? Why not just be specific about that?
Well, and we didn't actually reject that. That wasn't part of the discussion.
Okay.
But some of these are also existing MOUs, I should say existing relationships that they're not operating under an MOU. So there was also a request of giving flexibility, because they may be transitioning to an MOU. They may continue to operate outside of.
I guess my question, if may without further stipulation is too much flexibility. If we're ultimately still trying to make sure that people who are community health workers who are so critical are not uninsured people. That's all. I guess that's my question.
And I appreciate it. And we've had a number of discussions on whether or not we should actually hold this piece out. And the consensus from all stakeholders was that having it as a may still makes it part of the conversation, but gives the flexibility that everyone needs to move forward. Is there any further discussion on the amendments? Seeing none on the amendments, all in favor say aye. Anyone opposed, go ahead and raise your hand in the chat. Do I have a motion on the bill as amended?
Move the bill as amended.
Do I have a second?
Second.
All right, thank you. I'm never sure if my computer's frozen or not, because I don't always have a great signal. All right, it's been moved and seconded. Any further discussion on the bill as amended? Seeing none, all in favor say aye. Anyone opposed, go ahead and raise your hand in the chat. All right, seeing none, that bill passes unanimously.
737.
All right, thank you. All right. Oh, okay. So we are on House Bill 737. This is Public Health Non-Opioid Advanced Directive. Aaron just received the amendments, but so we're gonna talk about it. If the subcommittee feels comfortable, we can vote it. If not, we're gonna hold it. But these are consensus amendments. This is the bill that we held because there were some outstanding questions with Hospice of the Chesapeake. And so Aaron, if you can talk to us about the bill, do you have the amendments now?
The
Yes.
members should, yes.
Okay.
So this bill was discussed last week. The approach now being taken with the bill is to amend the current model advanced directive form that appears in the Health General article. In your reprint, it's the new language appears on bill page 9, which is the section of the model form related to pain relief. So you'll see the new language would be in bold small caps, and it provides that if you want to state your preference, initial one only. If you do not want to state a preference here, you would cross through the whole section. So the new language states that I understand that in cases of emergency where there is a substantial risk of death or or immediate and serious harm, and delaying treatment to obtain consent would adversely affect my health, healthcare providers may administer opioid medications in accordance with 5607 of the Health General article. And then you could initial the current language saying no matter what my condition, give me the medicine or other treatment I need to relieve pain. Or there's new language stating that unless medically indicated to control symptoms or unless in consultation with my healthcare agent, I do not wish to be offered or administered any opioid medications. And I believe, Delegate Bagnall, that is the extent of the amendments, but if I'm wrong, please correct me.
No, that is correct. And thank you, Aaron.
Oh, wait, sorry. We did discuss it last, so there is new language, but it was discussed last time. At the end of the form stating that if a healthcare provider is not subject to criminal prosecution or civil liability or deemed to have engaged in unprofessional conduct as determined by the appropriate licensing authority as a result of administering an opioid medication when the administration is medically indicated to control symptoms.
Yes, so we were taking let me just comment and then Delegate Hill will go to you, Delegate Hutchinson, and then Dr. Morheim. Let me start with we mirrored that language that was already in 5609 specific to this new section. We actually met with the doctors from Hospice of the Chesapeake who did have some outstanding concerns. It was their recommendation that we use the medically indicated language to control symptoms, or unless in consultation with their healthcare agent, which is the language from advanced directives, basically the language for medical proxy. So these were these were amendments that came from that conversation. Let me go to Delegate Hill and then Delegate Hutchinson. And then
I was just moving the amendments for discussion.
Oh, thank you. Do I have a second?
Second.
All right, it's been moved and seconded. All right, so for discussion, let me go to Delegate Hutchinson.
So a couple of things. So Aaron, has this completely resolved the hospice issues and their concern about this overall? And if there's anybody there from hospice, and I'd still like to hear from MedChi in their terms of their position on this as well. That's one. I still, and I'm hoping that we can hold this because I would really like to understand these amendments better that Aaron just rattled off as well. As I continue to look at this and say, those providers, the hospice providers and MedChi who are the closest to this situation of having to administer an opioid to an unconscious victim, I still think they can still do it under guidelines we have today. I just feel like we're creating an infinite loop here with this bill. And is it really doing anything versus putting some fear into what a medical provider could do in the face of an emergency? If I look at the testimony, the testimony came out, there was, 2 in favor, or, I was the bill sponsor, and I know, Madam Chair, you're the bill sponsor, but was Face Maryland and the manufacturer of a non-opioid drug who came to testify in favor of this bill. And yet we had opposition from those that are directly involved in this situation, administering it. If the patient's awake, the patient can decide yes or no they want to do. But, I'd really like to hear the doctor's position on you know, what they have to go through when it's a trauma victim, and that's the only choice they have. Anyway, so that's I'd like to hold, and I'd like to understand this amendment much better.
And that's no problem. That's why I said we're going to discuss it. But I wanted to give everyone an update. So we do have Peggy here from Hospice Chesapeake. We have John Fiastro. I keep saying that. I'm sorry, Peggy. John Fiastro, who was here as part of those discussions, and Dr. Morheim. So let me start with Peggy.
Thank you. I just wanted to correct the record. I'm Peggy Schmoda. I'm the Executive Director for the Hospice and Palliative Care Network of Maryland.
I'm sorry, I keep saying Hospice of the Chesapeake. My apologies.
Okay. No, that's perfectly fine. I just wanted to say, in our meeting, I believe it was yesterday, the time's already gotten away from me. But basically, it was with providers from the Hospice and Palliative Care Network of Maryland, just to correct the record. That's all. Thank you.
Let me go to John and then to Dr. Morheim.
Delegate, Dr. Morheim can go first.
Okay,
that's fine.
Dr. Morheim, go ahead.
All right, thank you. And I'm going to speak for MedChi and for the Maryland Council of Serious Illness, because I did have a chance to review the amendments. Thank John Fiastro for sending them to me. He's been very gracious to work on this bill with me, but the opposition of both still continues, largely for the reasons that Delegate Hutchinson just allowed. As amended, or with these amendments, and let me say the Serious Healthcare Council is created by the state. Actually, I was on it for my at least 10 or 15 years when I was in the legislature and continue active with it. And my career, if you don't know, is emergency medicine physician. So I've been on the front lines for this for 40-something years. And, you know, what their opposition continues in both cases. And what the bill ends up with this amendment is really doing the status quo. I mean, if you administer medicines appropriately, then you're okay. And if you don't, you're not. And that's pretty much what's left. So what's left is a bill that just restates the status quo, which only creates more confusion in a situation where you don't need more confusion because there's already a lot of confusion taking place and a lot of challenges and a lot of stress. And the advanced directive form, if you really want to accomplish them, and this is what I suggested to John to take back to Haley on, you know, let's promote completion of advanced directives, their availability, and people recognizing and using them. Opioids have a place. And if you, you know, and certainly in advanced illness, and people have air hunger and other kinds of issues, judiciously used, they're appropriate. You don't really have to worry about addiction because they're going to be at end of life care, unless it's, you know, in the major trauma situations. It's not going to come up. And so we don't see what this does. I did review this with Chris Kearney, and I am speaking for MedChi. Chris Kearney is a longtime palliative care physician. With all due respect, Delegate Bagnall, I appreciate your efforts on this. And, you know, there's other bills that I'm supporting you on, but this simply can't be one of them. And so I would suggest either hold or, you know, we'll work with in the interim to try to accomplish what we can. We all know there's an opioid crisis out there. This does not serve to address any of that. Thank you.
Thank you, Dr. Morheim. We are going to hold this bill. I will say that these are consensus amendments, but we are going to hold the bill because we do want to make sure that that we have spoken with all stakeholders. And I don't believe Dr. Morheim was at the hearing, but correct me if I'm wrong, but I do want to make sure that we're addressing the outstanding concerns.
I appreciate that, if I could just respond, you know, all stakeholders, I work with Peggy a lot, and she's on the Serious Health Council, but that's a whole broad spectrum of people, not just hospice, which has maybe a different perspective than those of us in the acute medical world and others.
Yeah, so, and our meeting yesterday, as
you
Peggy
can
said,
let me know when the next
version
of this meeting is. I'll be happy to attend and see if I can get Dr. Kearney there as well.
That would be great. Thank you so much. Delegate Hutchinson.
Thank you, Madam Chair. I would just like to ask Peggy directly. So where is the position from the hospices? I want to hear from you.
Thank you. Well, in our meeting yesterday, we did speak with John Fiestro, and of course, there were a couple other stakeholders there. We did come to, as Delegate Bagnall said, there was a consensus, the two amendments, right? So we changed the some of the terminology from medically necessary to medically indicated. The other consensus was that they added the term unless in consultation with my healthcare agent. So I do believe that with those changes, the group felt comfortable accepting those amendments.
Thank you.
Mhm.
All right, and I just realized for the members, I also got the time wrong. So we are going to adjourn and go straight to our voting session. My apologies. I misread my own notes. I'm going to hold this bill. That actually completes our work for today. So well done, everyone. And hopefully the chair won't be too upset with us. So we are going to go ahead and adjourn, and please head to